there is a biblical injunction about being careful where to cast your pearls. But Dr. Hayes, thank you so much for coming. I think your pearls were well received today. Our next speaker is sponsored by a great partner with the society, Intermountain Health. Anybody associated with Intermountain Health, if you'd stand, we'd like to give you a round of applause, please. Thank you very much. We do appreciate the sponsorship and really the clinicians and support we have in our community from Intermountain Health. Our next speaker is going to discuss advancements in cardiology. We'd like to welcome Dr. Mariam Nassif to the podium. My little anecdote with her is that she always has a smile for anyone in the hallways or the doctor's lounge at the hospital. So welcome.
Thank you very much for inviting me today to talk about what's new in my field, cardiology. And I thought I would talk about PET-CT because I felt it was relevant to a lot of primary care providers that take care of patients with pain and would like to know if the chest pain is cardiac or not, and inevitably will be ordering stress tests to figure out if the etiology is cardiac. And I have no, thank you. I have no relevant disclosures to this subject. There's a perception that coronary artery disease is a disease of the New World and of our modern people. But I'm here to tell you that coronary artery disease was present since BC era. And that was found out in the mummies from ancient Egypt, where they did CT scans on their arteries and found out atherosclerotic plaque in the arteries of their heart, their peripheral circulation, and also in their aorta. And we all were taught as medical students that the first medical definition of angina pectoris was by William Heberden in 1768, but it turns out that the first angina pectoris definition was actually by an ancient Egyptian physician who wrote his definition about angina pectoris and acute coronary syndrome on the Eber papyrus, which was written in 1550 BC. And he described both angina pectoris and acute coronary syndrome. And his description of angina pectoris is actually the second one. And he said, if thou examinest a man for illness in his cardia, and he has pains in his arm, in his breast, and inside of his cardia, and it is said of him, it's illness, then thou shalt say thereof, it is death that threatens him. So they knew that coronary artery disease was lethal even many, many years ago, 4,000 years ago, that it's a lethal disease. And we also know that because it is the leading cause of death in the United States and has been the leading cause of death for the last 15 years. Now, in 1979, Diamond and Forrester did this pretest probability tables for us to help clinicians that see patients with chest pain in the office to determine what is the likelihood that the chest pain is cardiac in origin. And they proposed that we use three things. We use the gender of the patient, the age of the patient, and the characteristics of the chest pain. And they proposed three characteristics for chest pain, which were substernal chest pain that is precipitated by exertion and relieved by rest. And if the patient had all three characteristics, they called that typical angina. And if they had two out of the three, they called it atypical angina. And if they had one of the three characteristics, they called it non-anginal. So let's take a patient that comes into our office that's 69 years old, and he's a gentleman that has typical angina. And in this situation, that patient would have, if you look on the typical angina category, and it's that last one, 69 here. It's a 94% chance that the chest pain was actually cardiac in etiology. Now, fast forward 2020, the European Society of Cardiology actually said, wait a minute, when we see a patient who's 69 years old that's coming in with chest pain, and it's typical chest pain, we haven't noticed that their pain is cardiac in 94% of the time. And so they decided that the Diamond and Forrester pretest probability tables have been overestimating the risk of coronary artery disease. And they came up with the updated Diamond and Forrester pretest probability, and they added to it another column, which is the colon of the dyspnea, which we use as dyspnea as angina equivalent, and they used still the sex and the age of the patient to determine what's the likelihood of this dyspnea being caused by coronary artery disease. Now, if we go and look at the updated Diamond and Forrester pretest probability and use that same gentleman who was 69 years old with typical chest pain, risk for having coronary artery disease as the cause of their chest pain would be more. So if we look at here, this patient would be in the 50% possibility of angina pectoris being the cause of his chest pain. And if we think about a 50% chance, we're talking about a flip of a coin. And certainly, if we are going to give the patient the possibility whether he has coronary artery disease or not and say it's a flip of a coin, that's not a very good way of determining his chest pain. So I wanted you to look here at the Bayesian analysis of CAD probability using a nuclear stress test. And basically, our gentleman who had 50% chance of pretest likelihood that he had coronary artery disease by the updated Diamond and Forrester. And we look at the blue curve. That blue curve is patients who had negative myocardial perfusion testing. And the pink curve is actually patients who had positive nuclear stress test. So we started with a probability of 50% that the chest pain was cardiac in nature. And then if he had negative stress test, then we came down to a post-test probability of 15%. On the other hand, if his test was positive, it put him at an 80% chance that his chest pain is coming secondary to coronary artery disease. So the nuclear stress test here was very helpful because it changed a flip of a coin to either 15% or 80%. Now, nuclear stress tests are not very helpful if we are in this side, which is very low possibility of having coronary artery disease, or this side where we are seeing very high possibility of coronary artery disease. It's very helpful in the intermediate risk patients. And I wanted to share with you the ischemic cascade because I feel the ischemic cascade gives us a lot of insight about what happens with ischemia and where our testing can be evaluating in the ischemic cascade and which tests are more sensitive and which tests are more specific and would help us determine which test would be better for the patient. And so if we look here on the x-axis, this area represents the non-obstructive coronary artery disease, and this area of the x-axis represents obstructive coronary artery disease, with this point being the point separating both, which we usually say it's around 70%. When patients have non-obstructive coronary artery disease, there's really not very many hemodynamic effects that are caused by this non-obstructive disease. And so most of our tests cannot detect this zone. The only test that can detect this non-obstructive disease, if we visualize the calcified plaque by a coronary calcium score, or we actually visualize the arteries itself by coronary CT angiography. But when we step into the obstructive coronary artery disease, this is when the ischemic cascade starts, and this is where functional testing can detect the disease. The first stage of the ischemic cascade is metabolic abnormalities, and these cannot be detected unless you're going to do metabolic imaging by PET-CT or by metabolic cardiac MRI. So we start detecting obstructive coronary artery disease when we reach this stage of decreased myocardial perfusion. And these can be detected by the nucleus testing or by cardiac MRI. And we move on to diastolic dysfunction, but we don't leverage that to tell us whether the patient has coronary artery disease or not, because diastolic dysfunction is very nonspecific. So you can see it in patients with obesity, with sleep apnea, with diabetes, as well as with coronary artery disease. So we actually don't use that for detection of CAD. Then we move to the systolic dysfunction, and this is when we see wall motion abnormalities. And we can see the wall motion abnormalities when the patients are studied by a stress echo or a dobutamine cardiac MRI. Then we get the EKG changes, which can be detected by the stress EKG. Then we get the symptoms of chest pain and angina equivalent. Now, when we're actually looking here at our testing, the tests that are lower down here are the more sensitive, and the tests that are up here are actually the tests that's more specific. So if you have a patient who has multiple risk factors for coronary artery disease, and this patient has a high likelihood that they will turn out to have coronary artery disease, you want to use the tests that are more sensitive, like nuclear stress testing and adenosine cardiac MRI. On the other hand, if you have a patient with low likelihood of coronary artery disease and you want to rule out that they have CAD, you want a more specific test, and so you'll go towards stress echo and stress EKG. Now, what is the basis of our nuclear ischemic imaging? The basis of our nuclear ischemic imaging is represented in this graph, which has on the x-axis the percent of stenosis in a blockage, and has on the y-axis the coronary reserve. When we look at the dashed line here, the curve is representing the myocardial blood flow during rest. And it's showing us that the myocardial blood flow during rest stays preserved at very high level of stenosis. It actually starts to drop at 85%. So a patient who's sedentary and resting and is not really doing very much will not have too many symptoms, even if he has significant obstructive coronary artery disease. On the other hand, if you look at the top curve there, the top curve represents the myocardial blood flow during stress. And the myocardial blood flow during stress starts to actually drop when the blockage is at 40, but not very significant. The steep drop starts at 70%, and that's when we say we're going to be able to pick it up by our stress testing. Now, I wanted to show you examples of nuclear images, and if you look at this, this is a polar map of the heart, where this portion is the anterior wall, this portion is the inferior wall, and this portion is the lateral wall. And in general, we say that this is usually basically the LAD territory, and this is usually the RCA territory, and this is usually the circumflex artery territory. Except in 15% of patients where the circ is dominant, the circ can actually cover part of the inferior wall as well. Now, this is the resting myocardial blood flow, and you can tell that there is uniform distribution of the radioactive isotope. Everything is looking the same color, and it's that orange color, which means there is good normal blood flow to the heart muscle. On the other hand, if you look at the stress myocardial blood flow for that gentleman, you can easily see that there is decreased myocardial blood flow to that patient, and it is in the anterior wall territory. So there is a reversible defect in that anterior wall, suggesting that there is disease in the LAD territory. We have the other example here, and you still can see that the rest images are showing uniform perfusion and good perfusion, which is going with our graph that the rest images, perfusion stays normal for a long time until very severe stenosis occur. And then on the stress images, you're seeing decreased perfusion in the inferior and infralateral wall. This is a patient who has normal myocardial perfusion, where the rest is showing the uniform perfusion and the stress is showing uniform perfusion. So this is a normal myocardial perfusion study. And these images are called the myocardial perfusion images, and it's only evaluated by just our visual evaluation. And this is what we have used for years when we were doing SPECT imaging. We were just using visual evaluation of the myocardial perfusion images to tell us if there is ischemia or not. Now, the era of PET-CT came, and it started in 2013. And actually, we got it in 2019. And since then, since PET-CT, we're no longer just looking at myocardial perfusion imaging and looking at the degree of ischemia visually. We're having many other things to look at with the PET-CT. And with PET-CT, there are two isotopes that are FDA approved, the N13 ammonia and the rubidium-82. The difference between the N13 ammonia and the rubidium-82 is the half-life. You can see that the half-life of the N13 ammonia is 10 minutes, while that of the rubidium-82 is 76 seconds. N13 ammonia requires a cyclotron on site. So if you don't have a large facility that have a cyclotron on site, you cannot basically have N13 ammonia to do your stress testing. So most other facilities are using the rubidium-82, which is a generator that you buy from the company every 4 to 6 weeks. And basically, that's how you get your isotope. But the problem with, if you're using the rubidium-82, your half-life is so short that you can only do pharmacologic stress testing. You cannot do treadmill with PET-CT with rubidium-82. So most of the facilities in Utah actually are using rubidium-82. So there is none of us that's using treadmill PET for our stress testing. We're all using pharmacologic stress testing. And this is the setup for the pharmacologic stress testing. This is our PET-CT. The patient lies on the table, the arms are up, and we do the injections of the vasodilator, which is the chemical that we use to stress the patient, and we inject the rubidium-82 for rest and for stress. Now, the vasodilator is actually what we use as a chemical to stress the patient. And there are 3 different adenosine receptor agonists that can be used to stress the patient, regadenosin, adenosine, and dipyridamole. Now, regadenosin is a selective adenosine agonist. So there are 4 adenosine receptors in the body. And the first one is the one that does the coronary vasodilation, and that's the one that we want to use for our chemical stress test. The A1, the A2B, and the A3 are not necessary at all for our test, but those 2 vasodilators are non-selective, so they activate everything. The regadenosin activate the coronary vasodilator in particular, and to a lesser extent, those 3. This is why regadenosin is considered the the drug of choice to actually do the pharmacologic stress testing because you get less side effects. And the side effects are heart block, chest pain, tachypnea, bronchospasms, and so these are the things that the patient may experience if you're using adenosine or dipyridamole, and to a lesser extent, they feel it with regadenoson. Now, this is why also we say if you have a patient with second or third AV block, it's a contraindication to get this pharmacologic stress test. If they have acute or severe asthma, they should not be getting that test. And one other thing with regadenoson is it decreases the seizures threshold. So if you have a patient who just had seizure or had many seizures, you will want to make sure that they do not get a pharmacologic stress testing with regadenoson. This is the protocol for the PET-CT, and we basically get the rest images, the stress images, the blood flows, and the calcium score. Notice here that the whole thing takes about 30 minutes. This is a significant improvement from the old test that we used to use, which is the Lexiscan Cardiolite, because that takes up to 2 hours to do. So it's a very efficient test when you compare it to what we had before. What do you get when you have an 82 rubidium PET-CT myocardial perfusion test? You get a coronary calcium score as part of the test. You get the myocardial perfusion images that I showed you that we visually evaluate. You get quantification of the myocardial blood flow, so you're able to measure the rest myocardial blood flow, the stress myocardial blood flow, and the coronary flow reserve, we calculate that by putting the stress above the rest and just divide it. And it tells us how much increase in the blood flow happened when you actually gave the vasodilator. So if you give the vasodilator and the myocardial blood flow increases by at least 2-folds, then that's considered normal. Anything less than 2-folds is considered not good. You also get the left ventricular ejection fraction, not only at rest as we used to get with our SPECT imaging, but you get it also at peak exercise. And that's very helpful, and you will see as we talk about it some more, how we use that for risk stratification. Now, this is a normal PET-CT. The patient had the myocardial perfusion imaging looking normal with no areas of decreased blood flow visually, had a 0 calcium score, and then when we look at the myocardial blood flow, you look at the stress myocardial blood flow, we say if the myocardial blood flow is 1.8 or above, then it's normal. So you see that the LED territory is above 1.8, the circumflex territory is above 1.8, the RCA is above 1.8, and the global, which is a combination of all three, was above 1.8. Then we look at the coronary flow reserve and see if the coronary flow reserve was above 2. We want to make sure that the patient has at least double the blood flow when they stress. And so if it's above 2, then we're in a good range. So this is a completely normal PET-CT. On the other hand, if you see that kind of calcium in the LED, this is extensive coronary artery calcification in the LED noted on the coronary calcium score with patchy area of calcification in the circumflex artery. This is a patient who has ischemia in the anterior wall, which is secondary to LED disease. And this is a very abnormal myocardial blood flow. And I wanted to show you that so you can tell when you get your reports and you can look at it. You see the LED here and you see the stress and it's below 1.8 and the coronary flow reserve is below 2. Look at the circumflex artery, it's way beyond 1.8, and the coronary flow reserve is still less than 2. And look at that RCA, it hardly had any increase in the blood flow with exercise, and this is the coronary flow reserve showing that it's less than 2. So this is a very severe a type of coronary artery disease with triple vessel disease or maybe even left main. So why should we do PET? We do PET because it has excellent diagnostic accuracy. So you see here that the PET-CT is compared to the SPECT, which what we were used to doing before, and the coronary CT angio. SPECT and coronary CT angio are pretty much the same accuracy, but PET is certainly more superior to them. It also had very high image quality. So the obese patients, the patients with large breasts, the gut uptake is much less in PET compared to SPECT. So if you're having a patient that seems to be challenging, I'm not going to promise you that it's the miracle test, but it's certainly going to give you images that are much better than what SPECT would give you. Now, it also is a very efficient protocol. So within 30 minutes, you're getting the resting image and you're getting the quantification of the rest. You're getting the stress image and the stress quantification. You're getting the coronary calcium score and you're getting an ejection fraction at rest and at peak stress. So it's a very efficient way of doing testing and it helps you throughput in your lab. And to add to that, it has very low radiation. So this is the radiation for the testing with nuclear that we are used to have. And the one that we use the most is this one, which is the single-day SPECT test where the patient get the rest and the stress in one day, and they get the radiation dose is 10 millisievert. And you can look here, and the PET actually has the lowest radiation that you can get. So it's very good when you want to save on radiation. And PET also gives us prognostic value that is much more than SPECT, because when we used to do SPECT, we used to depend on one thing, which is the ischemic burden. How big is the ischemic burden? Is it 10% or higher that put them at high risk, or is it below 10%, which put them at moderate to lower risk? But now we have many other things to look at to give us prognosis about the PET-CT. Now, when we talk about the ejection fraction, we used to get the ejection fraction from the SPECT occur at rest, and that's the only ejection fraction we get. But now we get ejection fraction at both rest and peak stress. And so when you're getting the ejection fraction at peak stress, you're supposed to get the ejection fraction gets stronger and the EF goes up. And so the more the EF goes up, the more the health of your heart. And so if at peak stress, the ejection fraction goes up by 5% or more, that has a 97% negative predictive value that you're dealing with a left main disease or a 3-vessel CAD. So it's very important to look at that peak stress EF and see how much the patient increased, and we call that EF reserve. If your EF reserve is high, that's a good indicator that you don't have any significant CAD. We also look at the coronary flow reserve, which we were talking about. It's that ability of the coronaries to increase the blood flow by at least double, or if not even more. And it goes beyond ischemic burden. So if you look here, these are patients that had no ischemia or had 1 to 9% ischemic burden, or 10% or more. And 10% or more are considered the high-risk patients. So if you look at the high-risk patients, even though they are high risk, you can still risk stratify them in the high risk based on your coronary flow reserve. If your coronary flow reserve is really bad, like the one that I showed you, you're at the worst possible risk. On the other hand, if it's slightly decreased, then you can be at a lower risk. And the same thing for the patients who have no ischemic burden. You think these are patients that don't have risk, but that's not true. If your coronary flow reserve is normal, then you are at the lowest risk. But if your coronary flow reserve is not normal, you can start thinking about balanced ischemia, where patients have triple vessel disease, but because it's balanced disease, they can be in that high-risk category. Now we talk about coronary calcium score, and coronary calcium score is one of those things that I feel are very, very important and have made a big difference in our cardiology world. And this is data from 2010 looking at just calcium score and deciding survival based on that. And they found out that if your calcium score was 0, your survival in 10 years is 99.4%. On the other hand, if your calcium score was 1,000 or above, your survival was 87.8%. So that simple test can tell us survival of patients for 10 years. Now, they also had a meta-analysis of 6 studies with 2,123 patients that had coronary calcium scores and had ischemia. And they looked at the ischemic prevalence in patients based on calcium score. So if you had a 0 calcium score, the prevalence of ischemia was 6.6%. On the other hand, if you had 400 or above, the ischemic prevalence was 23.6. So it's very telling about this calcium score, telling us that the incidence of ischemia is much higher. So calcium scoring, the presence of calcium is predictive of major adverse cardiovascular events independent from perfusion findings on MPI. And I will show you patients who have had normal myocardial perfusion images, and they took those 760 patients with normal myocardial perfusion images and looked at what were their calcium scores. And they found out that their calcium scores were 0 in only 35% of those patients. 65% of those patients had calcification, and some of them had calcification that was 1,000 or more. So these patients are not the same. Their prognosis is not the same. And I will show you here, this is a patient who has normal myocardial perfusion and has also 0 calcium score. And this is another patient that has normal myocardial perfusion and extensive coronary artery calcification. When we look at this slide, and I apologize that it's busy, but we'll take it one part at a time. This is a slide showing patients with normal myocardial perfusion in the light blue. And it's showing the annualized cardiac events for those patients. If the patient had a normal myocardial perfusion and a coronary calcium score of 0 to 10, their annualized cardiovascular event was 0.7%. But if they did have calcification of more than 400, their annualized cardiac event was 2.97. This is 4-fold increase in their annualized cardiac event just by having a higher calcium score. On the other hand, for all-cause death, in those patients who have normal myocardial perfusion and a calcium score of 0, their annualized all-cause of death was 0.6%. On the other hand, for those who had a calcium score of more than 400, it was 2 to 3.5-fold increase in their annualized all-cause death. So what's the strength of cardiac PET? We talked about the excellent diagnostic accuracy and the high image quality and the protocol efficiency and the low radiation, but the biggest strength of PET is really its ability to prognose those patients and telling us whether their prognosis are good or bad, because as you see, myocardial perfusion imaging alone is not sufficient. There are so many issues other than myocardial perfusion that can tell us what is the risk of this patient. And when should you order PET? If you order PET if you're going to do pharmacologic stress testing on that patient. PET is going to be so much superior than anything that LexiScan CardioLite will give you. And so if the patient is unable to exercise, or if they have a left bundle branch block or a pacemaker, because these group of people, if you put them on a treadmill, they'll give you a false positive test if you do so. And patients who have had a treadmill, whether a treadmill exercise test or a treadmill nuclear stress, and became back equivocal, PET offers so many things to look at that can help you determine the prognosis more than just imaging for ischemia. It's also very helpful in obese patients and in patients with large breast attenuation artifact. And PET can also help you with prognosis. So if you know that you have a patient with CAD, but you want to know their prognosis, you can use the PET to tell you the prognosis, as we said, looking at the ejection fraction, at the myocardial blood flow, at the coronary calcium score. The whole deal will give you better prognosis of these patients with CAD. And it's also very helpful to determine the response for therapy. So if we have a patient that is partially revascularized and you want to know what's the, your test is going to come back abnormal just because they are partially revascularized, but you want to know how much ischemia is left, you want to look at their myocardial blood flow, you want to look at their risk, then PET would be very helpful in those patients. Now, when don't you want to order a nuclear stress test and PET? You don't want to order it if the patient has a very, very low pretest likelihood. So if the patient has a very low pretest likelihood, it's not going to help you. It's just going to be not a very helpful test. Because as I showed you on that ischemic cascade, in those type of patients, you want more specific test, not a sensitive test. So this would be a person that would get an ETT, like a treadmill stress test, rather than getting a PET CT. And you don't need it in low-risk non-cardiac surgery. You don't need it if the patient has gotten a stent and is having no symptoms. In the past, we used to do a lot of testing for those people, but now we don't do that anymore. We also don't need it if a patient comes in and he's in their late 60s and is concerned about himself but is having no symptoms and does not have really a lot of risk factors. There is no justification for doing a PET for that patient or nuclear stress testing for that matter. So in these situations, we say nuclear stress testing and PET is not recommended. And with this, I am finished with my talk, and if anybody had any questions, I'm happy to answer.
Question? My question is, what is the threshold of calcium score index to allow us to order testing versus a referral to a cardiologist?
So in the past, they used to say 400 is our cutoff to do a stress testing, but the new appropriate criteria guidelines says 100. So now if you see a patient with a calcium score of 100, you can order a nuclear stress test for them.
Okay.
And I think that you can order the test as much as we can. Okay. If you feel comfortable ordering the test, you can. But again, once we get the results, and if it's non-obstructive, then that's fine. But if it is obstructive, they'll end up seeing us.
So if they're asymptomatic, there's technically, you do the exercise stress test over the PET.
Yes, so if you have a patient that is totally asymptomatic and you want to know if they have atherosclerotic disease, then I think your best test is the calcium score. Because remember when we were talking about patients that has non-obstructive disease, that the calcium score would pick it up. So if they're totally asymptomatic, I would start with a calcium score. And if the calcium score shows no evidence of calcification, then they have a 95% chance that they don't have any significant coronary artery disease. There's only a 5% chance that they have significant CAD. But if they are symptomatic and they are low-risk patients, and a young man that is coming in with chest discomfort and you don't have an alternative cardiac explanation, you can order a treadmill exercise test. But if you have a patient who has multiple risk factors, diabetes, coronary artery disease, hypertension, and so many risk factors and is symptomatic, then for sure that patient would deserve to be given a nuclear stress test. Okay. And if they can exercise, you can always do a treadmill nuclear stress test. But if they cannot exercise, think PET.
Okay. I don't know why, being a primary care, I find PET scans are quite intimidating. Are they more expensive? I have never ordered a PET scan. I've always done the exercise. or
It
the
depends
specs.
on the insurance. Some insurances are very difficult to get the PET through, and they'll want you to prove that their EKG is unreadable and they can't exercise, so that you cannot do a treadmill nuclear stress test before you order a PET CT with us. And so if the patient can exercise, I had a ton of slides here, and I don't know if you have them or not, but it was like 60 slides, and I didn't want to bore everybody with that. But one of the things that I wanted to show is that the most important prognostic thing that we do with the stress testing is the exercise capacity. It trumps everything else. If you have an excellent exercise capacity, even if you have severe disease, your prognosis is good. So if the patient can exercise, I still exercise people. There are patients that can exercise which you can't do those, like the left bundle or a pacemaker. But if they don't have these, you can do an exercise stress testing, and if they're but I don't like the pure treadmill very much because it's very high up on the specificity. And so if you have somebody with high risk, you don't want to do just a regular treadmill. You want to do the treadmill in addition to an imaging. But if you don't have a patient that can exercise and the patient needs to be done pharmacologically, then I think you should try PET. Now, there are certain, insurances that will have you go through the treadmill nuclear first, and then if it comes back equivocal, they'll let you do the PET. And sometimes you know that the patient is obese and they won't be able to do this, and but you have to prove it to them first that they need the PETs for them to actually give you a prior authorization. I think there are other insurances that are not as difficult, and so it depends on the insurance of the patient.
The other question is, when we get the scores back, at what level do you start them on a statin?
I'm sorry.
Say it one more time, Grace.
When you have a calcium score index, at what level do you start them on a statin drug? And risk management is a given. We give them all the risk, exercise and diet. 100 is your cutoff all the way around.
The 100
Okay.
is a cutoff. And this is not set in stone, because if you read the different studies, they'll give you different cutoffs. But 100 seems to be a good place to do it. Thank you.
We have one more question. We'll take one more question quickly.
I have a calcium score of 743. I've had it for 5 years, no angina. What's the explanation of the calcium?
Well, that's fantastic. That's good that you don't have angina. But have you done a stress test to look at whether it's obstructive or non-obstructive?
It's non-obstructive, according to
Well,
Dr. Lindley.
Yeah, and in these patients like yourself, the risk factor modification is the most important thing here. So your statins, your aspirin, your ACE inhibitors, these are very important, because these are what really decrease the risk for MACE, which is MI and strokes.
Thank you.
Thank you, Dr. Nassif. Wonderful. Of all the standardized tests that I'm proud of, you think back to high school and college and med school and licensing exams and all that, the one I'm least proud of would be my calcium score, unfortunately. It's a high one, but I'm not proud of it. We're going to just